Welcome to the future of wound care education and collaboration. Wound Masterclass Academy is delighted to present this immersive interactive event. This is a global event where our physical and virtual worlds will join to take wound care learning into a whole new dimension. Today we invite you to join 2 sessions with us, the Biofilm Masterclass with Dr. Mitch Sanders and Dr. Phil Bowler. And our next segment is a virtual interactive clinic that promises to revolutionize the way we experience wound care training. We encourage you to interact with us as much as you can over the next hour and a half. And thank you once again for joining us. So welcome to the Biofilm Masterclass. I'm joined today by Dr. Mitch Sanders and Dr. Phil Bowler. Welcome, gentlemen.
Welcome.
Hello.
Thanks very much. Would you like to introduce yourselves for the global audience?
Hi, everyone. My name is Phil Bowler. I've got a long career in wound care, in research and development. I worked for a commercial organisation for over 30 years. But my background is very much in the area of microbiology, clinical microbiology, particularly in understanding infections, what goes wrong, the implications of biofilm, looking at antimicrobial and anti-biofilm therapies as well. I've been very much involved in the development of wound dressings. Today I work as an independent consultant, helping various companies in the areas of infection control.
So Mitch Sanders, like Phil, I spent too much time in college and then started my first company, which was a diagnostic wound care company called ECI Biotech. We developed a diagnostic for broad spectrum for bacterial infection called Bacterial Status, and it's sold by WoundCheck. And Phil's very kind. He's written over 110 papers, has many patents, is considered one of the leading experts in biofilms in the world. So he's always been kind of a mentor to me. Always looked up to him and followed all his great work. So after doing diagnostics for 16 years, I joined a consulting firm and have developed numerous products in advanced wound care and focus a lot on the chronic inflammatory phase of disease in wound care, infection, actually cancer, and traumatic brain injury. So I'm studying neuroinflammatory diseases. When you get a TBI, it's just like getting a wound. And so I'm starting to study neuroinflammatory processes as well. More recently, we just launched a new consulting firm out of Alere Health called ProDev Labs. And ProDev Labs, the sponsor for this segment as well.
Thank you very much to ProDev Labs for their support. And thank you, gentlemen, for joining us with this global audience. Just a message for the audience here. If you'd like to text any questions into the chat, we'd be really happy to address any questions as you go along. If you'd like to ask a video question, that's also possible by just clicking that option on your screen. Phil, if I can come to you first, should we just talk a little bit about the definition for biofilms? Because I think it's an area where there are a lot of myths and misconceptions around it. So it'd be good just to start with the definition if we can.
Oh, well, yeah. I could talk all day about biofilm, of course, but yeah, I think I should start by saying that biofilm is nothing new. In fact, it's one of the oldest life forms on Earth, as bacteria evolved on Earth, getting on for 4 billion years ago now. Biofilm developed with it. But it's only over the last, I would say, 40 years that the term biofilm has been used in medicine and medical microbiology, and much more recently in wound care. But biofilm is the natural way and the predominant way in which bacteria live. Bacteria much prefer to attach to a surface, and once they've attached to a surface, it could be a fluid surface, not just a solid surface, but once they've attached to a surface, then they begin to secrete a polymeric matrix around themselves, which essentially is the biofilm. And the biofilm protects the bacteria within from the hostilities in the outside world. So it may be from extreme environmental conditions, It may be from immune cells, it may be antibiotics or biocides, but biofilm is the natural protective mechanism for bacterial survival.
And it's not just exopolysaccharides, it's got DNA in there and RNA. And the bacterial biofilm is usually deep enough that the middle of the biofilm is pretty senescent. And so it's resistant to mechanical shear as well as resistant to antibiotics.
And they're quite clever, these biofilms, aren't they? Because with the challenges that we set them, they often change their phenotype and genotype to kind of adapt. So they're in a process of adaptation for their survival as well. So that's an interesting thing for us to kind of tackle during this discussion too. Should we talk a little bit about why biofilm is important for us in the wound care community?
Well, from my perspective, and we should look beyond wound care as well, because biofilm is inextricably linked to chronic infections, irrespective of whether it be a chronic wound infection or a urinary tract infection or infections associated with cystic fibrosis or ear infections. These are all biofilm related infections. And the problem is that, well, biofilm is the root of that problem. And it's very difficult for antibiotics, antiseptics to work effectively against the biofilm, because the bacteria within the biofilm are protected. And these biofilm infections or chronic infections are very, very different from acute infections. And I published a paper on this with a wound ostomy incontinence nurse, Jenny Hurlow, back in 2022, where we looked to differentiate acute and chronic wound infections, because ultimately these infections need to be treated differently. And I can talk about this later, but whereas acute wound infections predominantly involve planktonic bacteria, so these are the free living highly metabolic cells that are invading host tissue, but are highly susceptible to antimicrobial agents, then biofilm, of course, is the real cause of these chronic infections, because biofilm remains. It's very difficult for antibiotics, for antiseptics to get to these bacteria. And what the biofilm can actually do is to take control of the host inflammatory response. And again, I'll talk about that a bit later, but for me, that is a really key aspect of biofilm in wounds, because it stays there, it's resilient, it's recalcitrant, it's difficult to remove, and it essentially hijacks the host inflammatory response.
And when you have a delayed inflammatory response, that often leads to poor outcomes for wound healing, as well as, when you have a deep biofilm infection, oftentimes you can have a graft loss when you're, putting a graft on. And so, you have to really, that's why people like to debride and clean out the wound bed before you use an expensive tissue or use a graft, because if the inflammatory phase is still stalled, you're never going to allow proliferation and healing to occur.
But we refer to, and it has been referred to a lot, that the inflammatory process is stalled. But in fact, in these wounds, it's highly active. There is so much inflammatory activity going on within these wounds. So again, if I go back to an acute wound infection where it could be a Staph aureus, a Pseudomonas, or a combination that are invading viable tissue, then of course the neutrophils, the first line of defense, immune defense, they come into that site. They try to directly attack the bacteria, take them within the cell. These neutrophils undergo an oxidative burst, and they've got various killing mechanisms for killing these bacterial cells. If they're not able to do that, then that's when antibiotics come in to help the neutrophils work more effectively. But in a biofilm situation, as I mentioned a few minutes ago, the biofilm actually hijacks the host inflammatory response. And this is a term that was coined by Randy Walcott probably 15 years or so ago now. And I think it's absolutely right, because the biofilm is tolerant to attack by immune cells. So as a foreign body, the biofilm is attracting neutrophils into that site. The neutrophils are trying to get to the bacteria. They can't get to the bacteria. So they start to get frustrated. They start to get angry. They recruit more neutrophils. The neutrophils then start to spill their enzymes and the toxic metabolites and the neutrophil extracellular traps into that surrounding environment, which ultimately damages host tissue. So the biofilm in a wound is working essentially like a parasite. It's using the host inflammatory response to its own benefit. And as the host inflammatory response damages host tissue, wound tissue, then as that devitalizes, it provides more nutrition for the biofilm. So getting rid of that biofilm is absolutely crucial, because, biofilm infections generally are characterized by these slow, sustained, persistent inflammatory processes. And that's because, the biofilm remains. So removing that biofilm, whether it by physical means, antimicrobial means, or various anti-biofilm strategies, is absolutely essential.
And the exotoxins that the bacteria secrete, these proteases, can hyperactivate the matrix metalloproteases of the host. So you have this advanced proliferative cycle of, and then you're degrading all the important growth factors and cytokines in the wound bed. And that's why you can't get moving out of the inflammatory phase.
Yeah. Yeah,
so it's a multifactorial blockade to healing, essentially, from what you're describing. And would it be safe to say that all chronic wounds or all hard to heal wounds have biofilms?
I wouldn't doubt.
Nick, please.
So one point before we get to that, let's talk about critical colonization and your thoughts around how things have changed a little bit around our thinking. So the old antithesis, what was E. Davis thinking about, you get to 10 to the fifth, you're going to have an infection, or it's going to lead to an infection. I've seen, obviously, when you have, it's really based on the bacteria, not just the bacterial load, but also the proteases or the toxins that the bacteria is secreting. Because when you have a bacteria like Strep pyogenes that's secreting a lot of protease, it can exacerbate an infection very quickly. And I think sometimes those proteases are used initially to kind of work their way in and start forming the biofilm. And then once they're in the biofilm, they can actually make more exotoxins as well. But Phil, talk about your thoughts around critical colonization. I think it was a good start, but I think we've kind of advanced our understanding of biofilms now, and also understanding of virulence, that it really depends on the virulence. And these are polymicrobial communities. You don't just have staph or Pseudomonas, you've got 2 or 3 other organisms in there as well.
Yeah. Okay. But before I get to critical colonization, Megan, I'll just go back to your question very briefly about my thoughts on, are all hard to heal or chronic wounds, do they all contain biofilm? I would say that the chances are yes. I'm not a clinician, but if I was a clinician and a wound wasn't healing normally, following that normal wound healing trajectory, it's gone off kilt somewhere, then I would immediately suspect biofilm. Absolutely. And I would look for anti-biofilm strategies. In terms of critical colonization, Mitch, it's a term that has been used 25 years now, must have been, if not longer. And it served its time. I think it had value, that point. So as bacteria colonize a wound, obviously with increasing colonization, then they can pose a greater problem. I think when critical colonization was first introduced, we weren't talking about biofilm in those days. It was about that balance between the host and the microorganisms. So as bacteria do colonize that wound, at what point, is that colonization critical in terms of stopping that wound from healing? And of course, every wound is different, every patient is different, the underlying comorbidities are different. So critical colonization, you can't say that critical colonization occurs at any one point in time. It will do for one patient, but not the same necessarily for another patient. But it was that sort of critical point at which the host is no longer able to control the microbial contamination, and it's tipping in favor of the microbes, and therefore you need additional support, antimicrobial support, whether it's antibiotics, antiseptics, debridement, whatever it is, to really get the wound and the host back in control of that. Today, critical colonization is not a term that I would use. I think it has been superseded. We talk about that continuum that you see in so many papers, the continuum from contamination, colonization through to infection, and somewhere along that line you've got critical colonization. I think today, 21st century, we're talking more about biofilm and the biofilm continuum. Of course, biofilm starts as planktonic cells attaching to a wound surface. If it's an acute wound and it's sterile at the outset, it gets contaminated with bacteria, there will be planktonic cells. But if they can adapt and attach very quickly, they will start to form biofilm. So you then got that biofilm continuum that can ultimately, maybe 48 hours later, lead to a mature biofilm that may or may not be visible to the naked eye. So I think it's more relevant these days to talk about a biofilm continuum, because I think that's more realistic of the clinical situation. But at what point do you control? Biofilm, as you mentioned earlier, mates, biofilm can form very, very quickly. As wound care practitioners, need to be looking for those signs of abnormal healing, things going a bit wrong, and look to anti-biofilm strategies as quickly as possible. Randy Walcott, again, one of the pioneers and leaders in the field, in recent times he's spoken about, when does a wound become chronic? Is it 30 days? Is it longer? But now we're considering biofilm. Biofilm, we know, forms very, very quickly. So a wound may start to become chronic within days, to that chronic non-healing situation. So again, his approach has very much been, treat early. If there are signs there, if there are warning signs there, don't wait 30 days for a wound to become chronic. Get on it straight away and apply appropriate wound hygiene to encourage that wound to heal as quickly and as effectively as possible.
And what I'm amazed at is that when you look at the wound from a clinical perspective, maybe 25% are clearly infected just visually, right? 25% are not, but there's this gray area of 50% that you really can't tell based on just clinical signs. And that's where the MolecuLight or other imaging capabilities have really enhanced our understanding that the biofilm can be very localized. Yeah. And sometimes it can be a deep tissue infection where you don't even see it, but it's brewing. And that's, we use the MolecuLight even in preclinical studies now to help us better understand, what is the biofilm doing in the context of a preclinical model. Because the challenge is, as I say, unless it's a overblown infection, it's obvious it's staph or it's Pseudomonas or, depending on the color, serratia. It's hard to know. If you have a stalled wound, you have to consider that it is likely has a biofilm, and that may be the etiology that's causing an issue. But there could be other conditions or other underlying. If you have a diabetic foot ulcer, you may just be stalled because you don't have enough ATP and there's a whole host of other things going on. Or if you have a VLU, you may have venous insufficiency, and that could be brewing. But I do think there is a clear indication when you have an infection, the cost of healthcare goes way up.
Yeah.
And also the concern about if you have an infection, you're more likely to have a lower LEA, lower extremity amputation. And so it can exacerbate the whole process of trying to heal the wound in the first place.
Yeah. You know, I think you touched on an important point there, Mitch, you know, in terms of sort of the subtle signs associated with chronic wound infections or in hard to heal wounds, because it's very, very different from clinical manifestations in an acute wound, of course, where you've got those actively invading planktonic cells. You know, the inflammatory signs are very obvious. You know, you have a inflammation, you have swelling, you have exudate, you have pain. You know, these are all very, very clear clinical signs of an acute wound infection. But in chronic wound infections, those signs are very subtle. And, you know, many experts have published on this over the years, and Jenny Hurlow and myself published it in the Journal of Wound Care, our paper differentiating acute and chronic wounds infections in 2022. But, you know, the signs with chronic wound infections, they are subtle. But when you review the literature, you see there are certain signs that keep coming back. You know, like sullen granulation tissue, maybe hypergranulation, malodor, bridging at the base of the wound, friable granulation tissue that bleeds easily. And so many of these signs are linked to biofilm as well. And in fact, earlier this year, published another paper where we, myself and Christine Murphy, a vascular nurse specialist in Ottawa, in Canada, introduced the term granulitis as a possible term to describe this biofilm-induced hyperinflammatory process, because it often gets missed, and it can't be missed. It needs to be treated. And again, back to another point that you mentioned, Mitch, you know, in terms of picking out that biofilm, yeah, then there are devices today. You referred to the fluorescent imaging device, the molecular device, which certainly is able to, how I define it, as these bacterial hotspots in the wound. And I think, you know, the company Molecular are doing more research now to associate that with biofilm presence as well. So technologies are certainly helping to identify this condition, but then it requires appropriate and very quick treatment.
When I came into wound care 30 years ago, all we had was Gary Sebald's Nerds and Stones. So it's the wound smell, is there erythema,
yeah,
and all those things. And the cool thing is now we have some, you know, there are some new tools and new diagnostics coming out that are really going to enhance our understanding of when you have you know, a true infection, or whether you have fresh granulation tissue, of, you know, how long are you making sure you don't over debride a wound, making sure that, you know, you sharp debrided enough so that you can get to healthy tissues so we can start healing again. Yeah. And so I think we're going to see tremendous advances in diagnostics. I think it delayed for quite a long time because of the regulatory issues around the US, certainly, where the only indication or the only endpoint that the FDA ever recognized was healing. And so to have an infection diagnostic was really a challenge, because we had to show that if this diagnostic went off and 2 weeks later went off again, then your wound wasn't going to heal. So instead of thinking about a diagnostic like sensitivity and specificity and area under the curve like you would for any other diagnostic, we were forced, Dr. Serena was forced to do like 650 patients for our first wound care diagnostic for bacterial infection, because there was no primary endpoint. And hopefully now where FDA is starting to recognize biofilms and debridement and all these other things that would have brought these technologies to market a lot faster. And I'm hoping it really advances the field over the next couple of years.
Absolutely.
What I'd like to do is change to fungal pathogens now and talk a little bit about Candida albicans as well as C. auris. We always think, for wound infections, C. auris is the most common fungal infection, but certainly, Candida albicans is the most common fungal infection. C. auris has become a really dangerously emerging pathogen because it's multi-drug resistant. And we've been making surface cleaning solutions for the EPA for a client. And other than C. diff, C. auris has been one of our biggest challenges that it took quite a while to figure out how to kill it in less than a minute with the right formulation, because it's really has some great pumps to pump out everything you try and put into it. And it is starting to show up in the wound clinics as well.
No, it is becoming a more recognized and notorious pathogen, as you say, Mitch. Multiple antibiotic resistance, responsible for more and more infections. So, it's an organism that we definitely need to keep our eye on in wound care. It's more of an opportunistic pathogen. You're less likely to find it in wounds generally than the bacterial pathogens. And of course, there are a good number of bacterial pathogens that are multiple resistant as well. Acineta baumannii, Klebsiella pneumoniae, multi-drug resistant Pseudomonas now as well. So we've got to be very mindful of those, because those are the organisms that you find most commonly in wounds. But I agree entirely, Mitch, that Candida auris is becoming a more significant problem, and especially in immunocompromised individuals and the like. This is where, as an opportunistic pathogen, Candida auris can take control, and once it does, it's extremely difficult to eliminate.
And super infections from the C. auris as well.
Absolutely.
So one of the things that I wanted to point out, and then in part of the I think we only have a few minutes left because we've been moving along so quickly, but part of the reason why we don't have any new antibiotics is because of resistance, and there weren't any good in vitro models. I think Greg Schultz had a great porcine explant model that everybody used, including my lab. The challenge with that model was that you had to use a lot of replicates, and it wasn't consistent enough to do high throughput screens for drug screenings for new antibiotics or new antimicrobials. And as we turn towards the next generation of therapies for biofilms, people like Kane Biotech, as an example, are focusing on ways of destroying the biofilm, which I think are really cool. But if we don't have good assays for those, then it makes it very difficult to study. And for those who do preclinical studies, like Phil and I, we've always been challenged trying to make an infection in a pig or in a diabetic mouse look as like a true infection, like it does in the clinical setting. That's always been a challenge, and that's how me and Hannah in my lab actually developed a way of 3D printing biofilms in a collagen substrate. And in vitro, what's been really cool is the standard deviation is very, very low, so you can go with one replicate and you can do it. It's so reproducible that every single 3D printed biofilm has the same number of bacteria, Staph aureus and Pseudomonas, that it makes it easy for high throughput screens. And you can do it in a 384 well format, and 96 well format, which is something we've never been able to do currently, which I think is a true innovation. The other thing that we found out more recently is when you take these 3D printed biofilms and you actually put them in a diabetic wound, you form this beautiful super infection that is completely resistant to even the beautiful products that Phil has made over the years at Convatec. And they're very resistant to antimicrobials and antibiotics. And they're so persistent that when you debride them out, they come right back. and they're so prominent that they after you cut them out, they spread right back, form the whole wound, and they actually form secondary wound sites because of the super infection that you have going on with this biofilm model. So we take a delayed mouse that normally delays up to, I don't know, 25 days, and now it goes out to 35 days, because with this infection, if you don't have something that will stop the biofilm, it won't heal. So I'm hoping that this model becomes a kind of a gold standard for doing future research in biofilm, antimicrobials and antibiotics.
Credit to you, Mitch, and team. Yeah, and hopefully it is, what you've developed there is a big step forward. Of course, one of the big challenges today is that most of the traditional microbiology testing that is performed around the world in microbiology labs involves looking at planktonic bacteria. You take a sample from, say, a wound, the bacteria in the biofilm form. If you culture them and they grow, they're now growing on a highly nutritious medium, and they can just revert to a planktonic form. So you're not testing them. Most laboratories don't test them as they're existing clinically. So the sooner that microbiology laboratories can move over to undertaking biofilm testing and biofilm test methods, the better. But of course, for that, methods have got to be relatively easy to perform, reproducible, across a whole series of labs across the world, even, so develop, the CDC reactor model, the model, and so forth. But if you've now developed a very simple 3D printed collagen substrate that you can use to assess antibiofilm agents in vitro, as well as transplanting to an animal and doing it in vivo experiments, then this is very exciting, and hopefully it's going to be a big step forward from a testing perspective, and certainly standardization of test methods.
I think we have a lot of hope for it, and the hope that the in vitro model will be an ASTM method soon, and that we'll also be applying
very good
3D printed biofilms of anyone's choice from our lab, just in an effort to collaborate, as well as to expand the research on this model system. And then, as I say, we have another paper for Megan to submit for Wound Masterclass, so she'll be very happy about the in vivo models that we hope to do soon. So I look forward to submitting a paper in the next couple of weeks.
Oh, we look forward to receiving it. But Mitch, I'm really interested to know what kind of infections you've managed to simulate in your 3D models, because I think that's what our kind of audience would be interested to hear a bit more. I think you've got a granulitis model and a deep wound infection model as well. So are you able to tell us a little bit more about that? We're going to share on the screen some of the photographs from your recent paper that you published with us in the meantime.
Yeah, and I think it goes back to Phil's recent paper around trying to come up, with the right. Phil's been great about coming up with the right language to describe a true biofilm infection. That's where his paper on granulitis is really important. And what we found is that certainly in vitro, we needed something that was going to be reproducible and consistent from lab to lab. And as Phil mentioned, those other CDC tests and the drip flow model and what have you, many of those tests are hard to do at scale for a high throughput screen. So when we're working with big pharma clients, and excitingly, many of them are interested in coming back into wound care, everybody said to me, don't you have a better model? Is there a way that we can do this reproducibly? And then consistently, when you have an infected model in the preclinical model, whether it's a porcine model or a rat or a mouse, you want it to truly represent what clinicians are seeing with real infections, real biofilm infections in the wound. So that's what we were trying to achieve, and I think we've really made some good progress there in the past. It's been 5 years to develop this, like everything, but I think it really has promise. So the point is that we've been able to make a clinical infection biofilm model that is persistent. It is pervasive. It is hard to remove, even with sharp debridement, because it always comes back. It's surprisingly, it also shows the benefit of imaging device. Oftentimes, you don't know where the biofilm is. You could tell that the wound's in this chronic inflamed state, but we could see right where it is in the wound, which is pretty exciting. And then the other point is that, we've taken kind of off-the-shelf antibiotics and other antimicrobials, shown that some are relatively decent at reducing the exopolysaccharide matrix. Some are better at destroying or at least reducing the bacterial bioburden, and others are very ineffective. And so it's a nice way to screen for kind of the best products that are in the industry. And Phil will tell you that not everybody's silver is good as another silver. There really is tremendous differences in the quality of the antimicrobials that are produced in wound care. And this would be a nice way of kind of leveling the playing field and maybe hopefully getting rid of some of these products that don't work or aren't very effective.
That's such an important point, Midge, that you brought up, as well as with Phil, is that we're looking for strategies to disrupt this biofilm, really. And part of the challenge we've had, obviously, is identifying the biofilm in the first place and bringing it into the sort of wound care terminology, that people start thinking that if a wound is stilled, then there may be biofilm as a big factor. But can I talk a little bit now just on treatments for antibiofilm treatment? So predominantly we're looking at antimicrobials and also physical mechanisms. Are there anything else that you think the audience should know about that?
A number of new products, and not all of them are kind of, I think some are out in Europe, Phil, right? But not all of them are approved by the FDA yet. There's a great product that's was developed by Kane Biotech called Dispersin B, which actually disrupts the exopolysaccharide matrix. And we're waiting on I don't think that's approved yet. I think they're still working through the FDA and other things. But there's some other products that are going after the nucleic acids. And then we think about some of the other formulations, antimicrobial formulations often have a detergent in them, so they can kind of disrupt the biofilm in a different way, get rid of the lipids, right? Mm-hmm. And so a product that I think of is Blastex. Maybe there's others and I think Blastex also has PHMB, doesn't it, Phil?
Yes, I think it does. Yeah.
So I think they're making combinations of products that have either something that that's a detergent based, but also has an antimicrobial in there. So you get a killing effect, and as well as a disruption of the biofilm through some sort of detergent. And then there's a lot of mechanical debriding agents out there, whether it's mist or ultrasound, or there's a lot of things that can really remove the biofilm that are very interesting, that are kind of coming to the foray in the industry.
Phil, do you have comments on that?
Yeah, sure, Megan. Yeah, I think there are two main aspects to dealing with biofilm. The first is to prevent biofilm formation in the first place. Going back to, I think, what was it? It was the 1970s now. Bill Costerton, one of the absolute pioneers in the field of biofilm, he published a paper in the Scientific American called How Bacteria Stick. Biofilm hadn't been introduced at that time. The term biofilm hadn't been introduced, but he was talking about these polysaccharide fibers. He referred to them as glycocalyx. and how they help bacteria to stick to surfaces. And what he said all those years ago was, maybe by preventing bacteria sticking, we can come up with a new antibiotic. That's how he referred to it at the time. So preventing bacteria sticking in the first place is the best way to go. Because if you can prevent bacteria sticking, you're going to prevent biofilm formation. So whether it's the physical nature of a surface, whether it's biochemical components of medical devices, then that is a way forward. Not just in wound care, but that is certainly a way forward in preventing biofilm formation and the subsequent problems associated with that. And then the rest is about really disrupting biofilm. And as Mitch said, there's many different approaches. And I think in wound care, the term wound hygiene has been used quite a lot recently, and there's been various publications referring to wound hygiene. And this is essentially a toolkit. It's a process involving nothing that's startling in wound care, but it is about debridement. It's about cleansers. It's about using appropriate antimicrobial dressings, because each of these components has got a role to play in wound care. The physical debridement, whether it is sharp or surgical, or a sterile gauze pad, or microfilaments or larvae, these are all methods of helping to remove what I always call the unwanted tissue, get rid of that unwanted tissue, which could be host devitalized tissue as well as biofilm. But that is a really key step in removing the bulk of the biofilm. But of course, it won't remove everything. So cleansers, they may be antimicrobial cleansers, they may be surfactants that are also important, as well as the antimicrobial dressings. And I think in that respect, and that's what I was very much involved with when I was at Comatec, was developing an antibiofilm wound dressing, which was a combination of antibiofilm components and the antimicrobial component, which is silver. Because by having those two antibiofilm components, they disrupt the biofilm, cause the biofilm to collapse, allowing the silver in the dressing to work much more effectively against the now exposed bacteria, the planktonic cells. And there have been some fantastic clinical results in that respect as well. So there are many new emerging technologies, but I think ultimately it's that whole wound care process, that whole wound hygiene process, involving several steps that are required really to get a grip of the biofilm and help these hard to heal wounds to heal.
And Phil had a great paper on how the pH of the wound changes when you have a biofilm, and the bacteria prefer more of an acidic pH. It creeps up over time, right, Phil? So they like a higher pH?
Yeah. Well, there've been quite a few publications on the effect of pH on wound healing, and certainly the chronic wounds, the hard to heal wounds, tend to have a pretty high pH. And again, there've been papers published on the optimal pH for activity of components, antimicrobial components like silver, which tends to be on the around neutral to acidic pH.
And then there's some new chemical debriders that are out in Europe that are not yet in the US, that are very, very low pH, almost acid solutions, if you will.
That's right.
Yeah. That's absolutely right. One of them is buffered. It is a hypochlorite, but it is buffered to take that pH up a little. But yeah, there are the chemical debriders as well. Yeah.
Neat.
Thank you very much.
Megan, I really the time.
Thank you very much, Dr. Sanders and Dr. Bowler. You know, it's amazing to have this discussion on such a vital topic like biofilm with you. And you've brought so much insight as to, you know, where we've come from and what the future is looking like for biofilm treatment. So thanks, gentlemen, for participating in this segment.
Really enjoyed it. Great to
Thanks
see
very
you.
much. Really enjoyed it too. Yeah, glad to be part.
Sure.
Thank you.
Thanks very
Bye.
much. Thanks very much. And we'll
Bye.
continue to take questions from the audience at this point. And we're going to go on now to our interactive patient clinics to look at some patient management cases with our global experts. Please stay tuned for our next segment, which is the Wound Masterclass Academy Interactive Patient Clinics. This is a fully interactive segment. Please continue to ask your questions in the group chat. Joining us in the interactive clinic today is Dr. Perry Mayer. He is Director of the Mayer Institute in Ontario and is also a board member of SANUWAVE. Dr. Joseph Byrne, an esteemed vascular surgeon who's also a medical legal consultant, specializing in vascular ulcers, diabetic foot ulcers, and medical legal reports. Last but not least, Dr. Matt Garofoulis, who is previous president of the American Podiatric Medical Association and is also charge of the Alliance of Wound Care Stakeholders, as well as medical director of AOTI, Advanced Oxygen Therapy. So thank you very much for joining us, gentlemen. I'm really looking forward to spending the next hour with you discussing these patients that we have attending our virtual clinic today. So let's get started. Please let me know if you can see my screen.
Yes.
Great.
Yeah.
Yes. Yes.
Great. Everybody can see that. Lovely. So this is a diabetic patient who is attending for the first time to our virtual clinic. So he is in his late 30s and he is a type 1 diabetic. He's otherwise generally fit and well, and he attends to us essentially complaining of discomfort around the lateral border of his foot. So shall we get started, gentlemen? Shall we talk a little bit about how do we assess this patient when he comes into our virtual clinic?
This is something in our wheelhouse. This is what we see all the time. When patients like this come in, it's that story of unknown wounds just appearing overnight. When we would assess this patient, obviously we'd sort of take a thorough history about their medical history and the like. But we narrow it down to their diabetic history and try to look at their target work and then go down to their feet and start examining them, thoroughly, again, vascular, neurological, and then inspection, and then then we have to start. So the first assessment is asking the questions, looking at their feet, and then formulating a plan, and then we start.
Right. Shall we talk a little bit about the type of vascular examination we would normally do in this kind of patient with a diabetic foot ulcer?
Yes, obviously, you would start with the pulses. Strong palpable pulses, of course, would be very nice. If there's any question about the pulses, we would always do an ankle brachial pressure index, measure the blood pressure in the dorsalis pedis and the posterior tibial arteries, and just use a blood pressure cuff to compare that to the arm pressure. And it's very simple, can be done by the nurse right at the bedside. That would give you, I think, a good idea of his basic vascular status. The skin looks surprisingly healthy. I'm not sure what part of the foot this is on, but I'm struck by the healthy appearance of the skin around the ulcer.
Yes, and this is a young patient, sort of first presentation of a wound. So
right.
Yeah.
Yeah, he appears vascularly intact with a little. Is that hair growth I see?
Yeah, it's pretty hair.
So that's
hairy
we don't
skin
get
there.
to see that
It's
very
just-
often in a diabetic patient.
That's true. And shall we talk a little bit about measuring the sort of neurovascular sensation?
Well, so
Yeah,
I don't know what you
Go ahead,
guys
Barry.
do, whether it is a monofilament, but we use a biothesiometer because we want some kind of a number. We wanted a number attached to, and that's validated. So I'd like to. I'm curious what others use to make it also quick. That's the other issue here.
And what sort of standardized, Dr. Mayer, you're dealing with a lot of diabetic foot ulcers in your practice. Do you have a sort of pro forma that you go through when you're doing your assessment, or is it something that you sort of dictate the letter afterwards, or what's your opinion on first of all, gathering that information from the history and the examination, but what's the best format when you've got a sort of high output clinical service that you're offering? What's the best way to ensure the documentation? What do you find works best in practice?
For their neurological assessment, the biothesiometer is the best way to do it, because you are actually generating a number. So the volts in our case, and that's easy, and it's standardized, reproducible, and gives you trackable kind of data, and sort of from a metrics perspective in the clinic, we wouldn't want to be horsing around with monofilaments or anything like that. Take too much time.
Absolutely. And Dr. Garofoulos, what sort of factors would be important for you at this stage when you're sort of determining treatment options for this kind of patient?
Well, if we're okay with his circulatory status, we understand his neurologic status. We'd like to understand a little bit about how the wound came about, when did the patient notice it, what he's done so far. If we understand that, then we can begin treatment of the wound, which this particular wound will need a bit of debridement to get started with. I have a sense that his vascular status is going to be in pretty good shape, so we do need to do some debridement. I'm a big fan of aggressive debridement, and so that would be something that we would do right off the bat. And once we can get a clearer picture of that wound, we can then understand what type of dressings we're going to put on that wound and what kind of treatments we're going to give it.
Fantastic. And Dr. Byrne, you and I have had this discussion before about, I think, a case that you were involved with reviewing of another clinician. And it was essentially a similar setting, wasn't it? A diabetic heel ulcer.
Yes, the problem with this patient is the physician who saw the patient didn't appreciate that the vascular situation was not very satisfactory. So you went ahead and debrided a very ischemic foot, and that, of course, is as I'm sure you all realize, is a huge mistake. It's like throwing gasoline on the fire. Shortly after there, 2 or 3 days later, the entire foot blew up with sepsis, and he ended up with a below-knee amputation. So I always emphasize you revascularize before you debride the wound, and I'm sure that's a principle that you're all very well aware of. But just to make that point.
Recap for the audience, yes. And we've got a live audience with us today, and we can take any questions from the audience if you want to just put that in the chat. So we all agree that vascular status is a really important factor to examine and document. Obviously, sensation we've discussed is vitally important. Are there any other factors that we'd want to know? We've mentioned the peri-wound area on examination, but is there anything else that you would normally examine in this sort of clinical scenario?
I would be wondering if there's some pressure from some shoe, or perhaps something that was in his shoe that he didn't notice. We had a patient once who had his watch fall into his shoe. We noticed that for 2 or 3 weeks. So, that's the other thing I would be concerned about, is did he injure this externally in some way?
Fantastic. And
sorry, it's a good opportunity. In our clinic, we're treating diabetes as well. So we're using the treatment of the diabetic foot as a lever to influence their diabetic management and their target work. And so we're using it as an educational opportunity. And so these ulcers, let's in this particular person who appears young, and early on, hairy wound and all, it's an opportunity because they're surprised. They don't know how in the world such a thing could occur. And here you are, you're the wound doc, and you're down there, carving away at the wound. It's an opportunity to share with them exactly why this is so serious and what is in store for them in the future. And so, and it's a teaching point. So they also are going to probably be coming certainly in our hands, they're going to be coming back to us probably more frequently than they would any other doctor, because they're high risk. They come back frequently for preventative care. And at all those times, you can use it as an education point. But at that moment, though, is a great time to teach and to allow that patient to understand better.
Right. And shall we talk a little bit about documenting the wound size, dimensions, parameters, essentially? What do you find in your practice? Do you find clinical photography of a wound so that you can monitor its progress over the sort of following weeks? Or do you have any other tips or tricks for our global audience? Now, bear in mind, some of our audience may be in areas where they have a high output patient caseload. And so just kind of trying to gauge from your advice. Obviously, previously we used to always measure the dimension of the wound. Sometimes people would do templates of the wound and put them in the paper notes. But obviously we're now moving a little bit to the digital paper-free side of things. So would value any advice from the panel.
Measuring is always important. Every visit needs to be documented with measurements. And now, of course, as you mentioned, with the digital era that we're in, photography is great. You can actually incorporate that into the medical record. So any method that is common for the area that you practice in would be perfectly acceptable. It's just important to do it on every visit.
I think when you come in the room and you look at a series of weekly photographs, you quickly grasp the idea of whether you're making progress or losing progress. So I really think everyone needs to make an effort, and I always emphasize this for the nursing homes and the hospitals as well. I think the wound care centers do seem to do a good job at this. It's part of their routine. But once they get into the hospital or the nursing home, people stop taking pictures, and I think this is when the communication breaks down and people don't realize that the wound's getting worse. The measurements don't often tell you the entire story. So I think if there's one thing we could do, we'd encourage everybody to try to get regular photographs.
Fantastic. And in terms of instigating treatment, so we've touched briefly on this kind of wound would generally need debridement and getting it back to a healthy wound bed, obviously after we've done the vascular assessment. And then can I kind of distill from your clinical experience, what kind of treatment options would you offer a patient like this generally if they came to see you in your clinic? So maybe Dr. G, I'll come to you first.
Sure. Well, definitely, if this is in a pressure-bearing area, we need to offload that wound right off the bat. Make sure that it's protected and there's no pressure on what we discover after we debride the wound. Then we have a variety of choices of wound dressings to put on there. Whatever we're most comfortable with as a practitioner is a great thing. You can go very simple, like a cadexim iodine dressing is very simple to put on if that's all that's needed for this type of wound. If you want to use a skin substitute, that is a great idea also, depending on what you discover after debridement. I'm a big fan of incorporating topical oxygen, cyclical pressurized topical oxygen as part of the treatment regime, so that you can use the dressing of your choice as well as the added therapy of oxygenating this wound. Typically, this wound is looking to me like it needs some therapy like that very quickly, and it'll help speed the healing process and give that wound a more durable and sustaining outcome.
Thank you very much. Do you think there's any role in negative pressure wound therapy in this kind of wound?
Yes, there could very well be a role for negative pressure, depending on the drainage that's coming out of this wound and what you discover after debridement. Negative pressure could be an option for first start.
And Dr. Mayer, if I come to you next, what's your feeling on this kind of wound and the types of wounds that you manage in your institute?
Well, so here up in Canada, we are somewhat limited to what kind of products we're going to be using, and skin substitutes we'd love to be able to. I certainly would love to get my hands on them on a regular basis, but we do not. So, but with regards to this patient, I think we all would agree that offloading, debridement, and putting something on in an advanced treatment modality mode is what will get this person back in action. And these are, you know, particularly if they're younger, they're a little bit sort of easier to get to do that. But the automatic thing that we would do is we would put them into like a post-op shoe that kind of slows them down a bit and gives them some room up in the forefoot, and allows that wound to be dressed. And we're lucky here in Ontario, in particular, we have a home care nursing that is excellent, and we can send out orders and have that wound dressed out in the field to hold them off until they can come back to see us for wound care. But again, we would probably, you know, the advanced wound treatment modality, you know, it's your choice. Certainly the standard ones, like Cadexor is an excellent choice, and this looks like a kind of smallish kind of wound, so it'd be kind of good that way. But we would, if it was a bit stubborn, we would start using some external modalities, and there's lots of them out there. We like our shockwave therapy. It is very helpful in wounds like this to get them going. We would probably reserve it for a little bit later, but it is very helpful. But again, these are relatively straightforward wounds that would probably respond to the offloading debridement, putting something on it kind of approach.
And I suppose one factor that we've discussed also is that we're assuming that this wound is not infected, but obviously as part of our assessment when we're doing the vascular and neurological assessment, we would also, if there was clinical suspicion, would you take a swab normally if a patient like this had come in acutely to your clinic, or would you just judge it whether clinically looks infected or looks colonized?
I do like to take a culture, one culture at least at the beginning. I think it's a simple thing to do. It sometimes will be really helpful. The other thing I would say, there's no question there's a lot of significant bacteria here. I would, if I had it available, I would like some sort of a cellulose collagen dressing, maybe one that had silver in it, like Prisma. So you'd have both the collagen, which would soak up the destructive enzymes. So the enzymes will degrade the collagen instead of degrading your healing wound. And you would also have the topical antibiotic coverage.
Thank you very much, gentlemen. Shall we move on to our next patient now? Let's see, if you just let me know if you can see the screen now. We have this patient who is African-American, and he essentially has an area on the inside medial aspect of his right lower leg. And this wound has been present for 3 months, and it has been resistant to any topical treatments, including basic dressings and also some advanced dressings. Would we like to have a discussion about what sort of factors we would like to know about this patient? So, Mr. Burns, Dr. Burns, shall I come to you first?
Yes, well, I think the first thing I would ask is whether he has sickle cell disease or not. This is certainly one reason to have such a refractory ulcer. I also think he clearly has some venous disease. You can see he's got significant edema. He has a lot of telangiectasias down by the distal part of the ankle. So this certainly could be a multifactorial ulcer, but I think that compression would probably be something I would try in this wound. If it's a sickle cell ulcer, they're very difficult to treat no matter how you do it. But I think I would start out with compression and see if that would assist this ulcer.
Right. And in terms of assessment of this wound, would go through the same, I guess, checks that we did with the previous patient, in that we're checking the vascular status, neurological status, and perhaps, as you've mentioned, consider doing some systemic blood tests, as well as a sickle cell test. So talking about considering biopsy or any atypical presentations, if you had a patient that had a wound that was resistant to other treatment modalities, are there any other sort of considerations you would make in terms of other diagnostics?
Did you say that that a biopsy had been taken, or that?
Not yet. No, I
No,
just.
so we should take I think we should take a biopsy of that. And even so, not only that, a biopsy, but for pathology, but we should get a good core biopsy for culture to see if there's anything odd in that growing in there. And was there anything in the history about how it started?
There wasn't any recent travel. I think that's what you're sort of kind of
Well, a
discussing.
little bit.
Yeah,
Yeah.
absolutely. So obviously that's another factor that is important for any patient to ask whether there's been any travel anywhere, whether there have been any insect bites. I mean, I suppose also kind of tick-borne conditions may need to be kind of consideration. So we talk a little bit, Dr. Byrne, me and you've discussed before how some conditions can be easily missed in early stages.
Yes, I certainly agree. I think a biopsy is very important at this point, and sometimes you will find something surprising. The one that I talked with you about the most, I think, is pyoderma gangrenosum, which is one that I have found to be surprisingly much more common than you would expect. It's supposed to be a disease of 1 in 100,000 people, but we would often collect a census of 10 or 15 of these patients in a wound care center that come from all over.
Yeah.
So that's one thing I would be concerned about right off the bat. The malignancy also would be a possibility in this wound, but I think this is where the biopsy is going to really be helpful off the bat to really get you started in the right direction.
Great, thanks, gentlemen. And so this actually turned out to be a venous leg ulcer. So we've talked a little bit about management of that condition.
Well, compression of a venous leg ulcer is the gold standard, so we always need to compress this. Again, if it's a simple venous ulcer, we need to understand from a vascular point of view, does the patient need any surgical intervention, any ligation or anything like that to help control an underlying source of ulceration? And if that needs to be done, it should be done right away. If it's okay and isn't needed, then go ahead and treat with compression, a topical dressing, some debridement. Of course, these can be very painful, so you may need to use an anesthetic agent or take the patient to the OR to do the debridement. But the wound should be cleaned up at some point, and then the compression. This is another case where we would use a cyclical pressurized topical oxygen because it offers a mode of compression as well as oxygenation to these tissues. So I think you get the whole package. Again, if it's a draining wound, if there's a lot of drainage, you may want to use a little bit of negative pressure on this perhaps. But there's all sorts of modalities that we can use in treating a venous stasis ulcer that'll help speed up the healing process and give it sustainability down the road.
And are there any sort of comments, Dr. Byrne, about medical legal aspects of this type of wound? Are there any tips and tricks for us as clinicians to bear in mind when documenting?
Yes. Well, of course, as we discussed our last time out, the most common cause for lawsuits in leg ulcers is failure to make the correct diagnosis. So there again, I think the biopsy is important. And most of the things that I see go wrong are in wounds that were left too long without a tissue diagnosis. So that again, I think getting that done pretty early is important.
And Dr. Garofoulis also mentioned a really important point. Obviously, anything that we suspect may be a venous leg ulcer is important to get that early imaging, duplex imaging of the superficial and deep venous systems and get that organized and documented so that at least you can exclude that as a reason for a wound that's not healing.
Yeah, that's very important. I do that on every venous stasis ulcer that comes in, so we get a clear picture of what's happening beneath the surface of the skin.
And in terms of distribution of venous leg ulcers, what sort of, for our global audience who may not be, have as much expertise as this panel in obviously seeing patients with venous leg ulcers, what kind of distributions are you typically considering venous leg ulcers for appearing?
Well, we get distributions along the medial aspect of the leg, sometimes laterally as well, various depth and diameters depending on the underlying disease. But I think as soon as you see an ulcer coming in that's on the lower leg, the first thing you're going to think about is, okay, let's see if this is a venous leg ulcer. But you also have to bear in mind the differential diagnosis that we all talked about earlier of the different things that this could be. Starting off with the initial hunch that it's a venous leg ulcer is great, but you also have to look at all the other possibilities that are available as well.
I suppose the other possibilities are arterial ulceration or mixed venous and arterial ulceration. And I think, Dr. Brown, this is something you've had a lot of experience over the years in vascular surgery.
Yes, I think it's that so many people have a combination of arterial and venous disease that it's very important to try to differentiate which is the most important part of the pathology. Certainly, again, we developed a rule that we would not put compression wraps on a patient unless we had an ankle brachial pressure index on the chart. What happens is someone will write down that they felt pulses, and then all the people that come along after that refer to that first note. And it's easy to fall into the trap of this is a venous ulcer, and we keep treating it and treating it. And next thing you know, 2 months has gone by and we've lost important time. So yes, I think before you compress a leg like this, if you can't feel the pulses clearly, probably even if you can, it's not a bad idea to make a policy in your clinic of having an ABPI on the chart.
All right. And in terms of documentation, do we find that it's easier that we just document each patient individually, or do we find that pro formas work in a high output setting? What's your feeling on that? Do you think the pro forma with the check boxes actually will kind of remind you not to miss any aspects of that history or examination, or do you find that it's actually better just to have your own system of taking that history, examining and documenting?
I think
pro
that
forma is fine as long as it's broad enough.
And the pro forma, it is totally fine for sure, but I find that people, well, let's just say that in our clinic, we have a routine where we go through, and documentation is photographic. And the checkbox part of it, our problem, because they use that in the hospital in our town, and it turns out that they check boxes and don't think about what they're actually doing. So it's actually not a exercise in examination; it's an exercise in documentation, and that's different. So so that's a distinction that I think it should be made, that these efficiencies are really good if you're accurate in what you're actually putting down there and not doing it just for documentation purposes. So
it's quite easy, I guess, to be blinkered when you're in wound care. If someone comes in and it's been referred to you as a venous leg ulcer or a diabetic foot ulcer, I suppose it can become quite blinkered, is that you think that's the diagnosis, and then therefore you instigate a chain of treatment options related to what you thought your diagnosis was initially. And I suppose the pro forma is the same, because the checkboxes are all there. You may not be looking for those features that you would be looking at if you were just documenting yourself. You maybe go into this autopilot mode where it's a checkbox and it doesn't require much thinking behind that, ticking that box in essence. So
is the pro forma, I'm curious now, because is pro forma kind of documentation common, down in the States? Is that or over in Europe and England, is that a common way for clinics to document their examinations?
Well, it can be, especially in a very busy clinic. They just want to have a checkbox that you go down. But I think that you want to make sure, like I mentioned earlier, that if you do it that way, that it's broad enough so that you have the option of going down a slightly different path, so you don't miss any of the various diagnoses that we discussed as a possibility here. You sure don't want to miss those. So that type of a methodology will work fine as long as it's broad enough.
Right. Yeah.
absolutely. Okay, so we're on to this next patient now, who essentially had a period of immobilization and was an inpatient on the surgical ward, and has been referred up for basically wound assessment. So shall we talk through this one together?
Wow.
Yes, I think
Yeah,
this is,
It's just
to my view,
Wow.
this is a classical, Dr. Fife calls this an angiosomal infarct. It looks to me like there's been an occlusion of the blood vessels to this area of the sacrum. The whole area has died. This is different than just to say a straightforward pressure ulcer. This to me looks more like almost a widespread infarction. When these patients are close to death, it's called a Kennedy terminal ulcer, but I think it's also occurs now in many of the patients that we have who are so old and in the hospital with multiple organ system failure. So I would put this in that category.
And in terms of, obviously, a lot of these patients may be coming to us from nursing home settings. What sort of aspects should we consider with patients like this in terms of, obviously, documentation? And Dr. Byrne, you've seen a lot of medical legal cases similar to this.
The important thing, you and I have talked before about this shocking fact that there are 17,000 lawsuits a year in the United States over pressure ulcers. It's a shocking number. It's hard to believe, but these are the easiest things for someone to pick up on. We don't, if a patient has heart failure, we don't say, well, who was negligent here, or renal failure, but it's somehow when the skin fails, people immediately begin to want to sue the hospital or the nursing home. So I think to me, the key here is communication with the patient and the family. And this is also where I think the pictures come into play. You need to show the family and the patient these pictures, impress on them that this is a serious problem, tell them what you're going to do about this. And there has to be regular communication and follow-up, because if you let this problem fester, you're going to be seeing the lawyer next. So again, communication, documentation with photos, I think this is the key to warding those off.
Right, and absolutely. So this may have been an earlier picture of the same injury essentially progressing. So if we sort of turn the clock back, what would we do at this stage to avoid things getting worse in terms of progressing onto a stage that's going to need either major reconstruction or other options which are more advanced?
Well, the obviously the main culprit is the pressure. So I think that the sleeping surface has to be topped up and properly assessed, and certainly in a nursing home, if that's where they're residing, that needs to be a priority. And the physician and the nursing staff need to be in tune with each other to understand what it means to maneuver such a patient, that those patients need to be moved. They need to be repositioned frequently. And then the dressing choices, I mean, there's a lot to choose from, but certainly you also have to be aware that they can't be sitting there in their bed with a sopping wet dressing on. That also needs to be considered. Otherwise, the wound will get worse just for that very reason. And forget about the pressure part of it. So this is it's a big problem. I don't, in the hospitals, it's shocking now, even with major, publicized cases of pressure injuries. They're not in tune with each other. The teams don't understand what's needed. This is a really terrible problem here. But in this particular case, just maneuvering the patient, rotating them or repositioning, and a new surface would do wonders for this person.
Mm-hmm. And any other factors such as nutrition and obviously establishing the other patients' comorbidities. So I guess we're looking here now for tips and tricks on which patients should we keep in that red flag category to try and avoid them from getting into that situation. So essentially looking at patient factors, predominantly patients perhaps with low albumins, poor nutrition, maybe on long-term steroids, compromised patients, patients who are on long-term bed rest. But it's essentially trying to do that pressure injury prevention.
Yes, I
I would-
certainly agree with all those things. And one thing I'd like to ask the panel, I noticed in this wound, maybe you could show it again, there is a rolling in of the edge, some epibole there. And I always struggle with at the top, for example, or maybe from 12 o'clock to 3 o'clock, you see the rolled ridge there of
Yeah.
epibole. I wonder how important the panel feels it is to try to debride that. Should you leave that alone, or should you try to remove that? When you're going to obviously be debriding this wound, but I guess my question is, where do you stop when you get to the margin in a wound like this?
Well, that edge is going to have the most difficult part, the difficult time to heal out of all the rest of this wound. So it's going to have to be addressed at some point. The biggest factor is, when do you address it? Do you address it right off the bat? Or are you going to wait and see if you get healing in the rest of the wound? So you want to limit the amount of times this patient has to go to surgery or to have that type of debridement here. But yeah, that edge of the wound is going to be the most challenging part to heal.
It's interesting so we would do two things. We would start the wound healing process normally. We would debride and then let it start going with whatever dressing we're going to use. See what the rest of the wound, so the bottom half of that wound, see what it does and how the skin moves, how the cells move around and get moving. And then at the same time, take a look and see whether that ridge up at the top end starts to develop some undermining, and whether you can get it to kind of start to kind of be more contiguous with the wound bed, just so that you're not really sort of carving up the patient too much on the initial phases, and you'll see how the wound responds. But so that would be kind of the one scenario. But we also use it so that our shockwave therapy that we use is quite handy in that regard, because that is kind of like scar tissue in a sense, and the shockwave therapy has a very interesting effect in that it thins that out, so to speak. And so we would consider that as well in this particular wound for that very reason.
So essentially, we're looking at debridement, and then I guess the reconstructive ladder for us would be debridement, simple dressings, debridement, negative pressure wound therapy, debridement, rotational flap. And I guess with the rotational flap, we're looking at how much I mean, from a plastics perspective, there is a lot of skin laxity to the right of that wound, which is superior, and also to the inferior portion. So in terms of being able to rotate healthy tissue, and obviously the main factor is, will this reoccur because of the factors that produce the original area of pressure? And then I guess also the next, if we didn't want to consider reconstruction with a rotational flap, would be looking at debridement and any advanced modalities that may convert this somewhat chronic wound to try and flick that switch and make it into an acute wound, just to try and stimulate healing. I think with that, we'll close our interactive patient clinic. Thank you very much to all of our panel today for sharing their expertise. It's really been a really good experience to kind of discuss these patients with you in this sort of setting. So thank you again for all your time and effort today.
Thank you.
Thank you for the
Thank you.
invitation.
Pleasure.
Thank you very much, and enjoy the rest of your day.